Hello guys, good morning. Hello everyone, good morning. So shall we start with our UVEA quiz discussion? All right. So the first question is a very easy question, right? I think so. Pizza pie appearance is characteristic of. Yeah, pizza pie appearance is characteristic of. Option A, sarcoidosis chorioretinitis. Option B, CMV chorioretinitis. Option C, toxoplasma chorioretinitis. Option D, rubella chorioretinitis. So basically, it's a posterior uveitis caused by which organism or a non-infectious cause where you've got this pizza pie appearance. See, pizza pie appearance is seen classically in CMV chorioretinitis, cytomegalovirus chorioretinitis, a very, very important question. It's a one-liner. So you also have other names or descriptions for the same. So one is pizza pie appearance, which was asked in the question. The other one is sauce and cheese appearance and brush fire appearance. All of them refer to CMV chorioretinitis. Okay. So cytomegalovirus chorioretinitis goes by the name or by the description. Pizza pie appearance or sauce and cheese appearance, brush fire appearance. Yes, because it's like a forest on fire. Okay. So that is important. It's a very, very easy one-liner. Okay. So let's move on to the next question. Again, it's a very easy question. Lish nodules are found in. Where are lish nodules seen? So lish nodules are seen. It's you don't even have to look at the options for this. So lish nodules are seen in neurofibromatosis 1. Okay, lish nodules are seen in NF1, neurofibromatosis 1. So these are nodules, non-inflammatory nodules seen on the iris, the lish nodules. Yeah, and these are actually iris hamartomas. Okay, so pathologically or histologically they are iris hamartomas found in NF1. In leprosy, what do you see? In leprosy we see iris pearls. Okay. Now the next question again is a previously asked question. Number of ciliary processes in each eye. It is 60 to 80 in number. Okay, so that's what the textbook says. So 120 million, 10, 120, 80. So 80 is your number. Now I have even given 120 million. Do we have anything 120 million in the eye? 120 million rods are there in each eye. Okay, 120 million rods are there in each eye. Ciliary process, the finger-like process in the pars plicata, you got 80 of them. Okay, 80 in each eye. Now next question, which of the following is implicated in the pathogenesis of Fuchs heterochromic iridocyclitis? Now Fuchs heterochromic iridocyclitis, you all must be thinking, madam is so fond of Fuchs heterochromic iridocyclitis. Yes, it is important. So Fuchs heterochromic iridocyclitis, in the pathogenesis, one that is important is rubella, and another one is toxoplasma. Okay, so both rubella and toxoplasma are implicated in the pathogenesis of Fuchs. So please remember rubella and toxo, rub and toxo. Okay, so both of them, but in my options I'd given only rubella. So you had HIV, Shigella, HSV, rubella. So rubella is the answer. Okay, so the question that we are discussing is, which of the following is implicated in the pathogenesis of Fuchs heterochromic iridocyclitis? It is rubella. Okay. What other organism? Because you are attending my class, you should know something better than the rest. So rubella, toxoplasmosis also. Okay. So rubella is quite common. Now, so nowadays they also found out that toxo is also implicated in the pathogenesis of Fuchs uveitis syndrome or Fuchs heterochromic iridocyclitis. Choroidal vessels are best visualized on option A, OCT, fluorescein angiography, option C, flow cytometry, option D, indocyanine green angiography. Good morning, BU. Good morning. See, there are two options here. Choroidal vessels are visualized on, but my question is best visualized on. It can be seen on OCT. You can see choriocapillaries, you can see the Sattler's layer, you can see the Haller's layer. Everything you can see on extended depth OCT. Nowadays, you can see it beautifully. Fluorescein angiography also you can see the choroidal vessel pattern. Indocyanine green angiography, yes, very well you can see. Flow cytometry, guys, flow cytometry is for your cells. Okay, when you run your blood samples or your tissue samples, you're looking for the cells and you're marking the cells. That is flow cytometry, nothing to do with ophthal here. Okay, it's not an in vivo procedure at all. So out of these three options, which is the best? The best is ICG angiography, indocyanine green angiography. Is that clear? So indocyanine green angiography is the best to visualize choroidal vessels. Now, can I visualize choroidal vessels on OCT? Yes. On FFA, yes, I can. The choriocapillaries, yes. May not be the huge vessels, but yes, the choriocapillaries, yes, we can see the background choroidal fluorescence. Best ICG. Is that clear? ICG angiography. Now, next question. Painful red eye with photophobia and constricted pupil is suggestive of. Okay, so patient comes with a red eye, there's a pain and photophobia, constricted pupil, nothing else. They're not talking about this decreased vision or anything. Let's see. Conjunctivitis. See, conjunctivitis, generally there's no pain, there's red eye. Yes, there's no photophobia only in certain entities like epidemic keratoconjunctivitis, or when there is a corneal infiltration, as in flictanular keratoconjunctivitis, you can have photophobia, right? Otherwise, generally conjunctivitis does not have photophobia. And they've also said constricted pupil. Conjunctivitis and pupil, no way, no connection at all. So conjunctivitis is ruled out. Posterior uveitis, guys, posterior uveitis is painless. Dard nahi hota. There is no pain. Vali kadayadu. Okay. So posterior uveitis, there is no pain. There is no pain fibers. There are no pain fibers in the retina, in the choroid, in the vitreous. So posterior uveitis, there is no pain. So patient comes with painful red eye, photophobia. No. So posterior uveitis is ruled out. Next is anterior uveitis. Looks like anterior uveitis, you have a red eye, you have pain and photophobia. Constricted pupil, yes, in the acute stage it is constricted. Yes, there is meiosis. I think that is the answer. Let's anyway look at option D, angle closure glaucoma. Guys, angle closure glaucoma, you can have pain, a red eye, but there is characteristically a dilated, a mid-dilated pupil. Okay, angle closure attack or angle closure glaucoma. So that is ruled out. So there is, it's not the answer. So the answer here is anterior uveitis. Is that clear to everyone? Pakka? This question, no doubts? Okay, which of the following drugs is used to decrease IOP in anterior uveitis? See, listen, read this question very, very carefully. The question asks, what is a drug you will use to decrease the intraocular pressure in anterior uveitis? Because in anterior uveitis, sometimes the IOP can be raised, the intraocular pressure can be raised. Now, how do you decrease the IOP? Pilocarpine, you will never give an anterior uveitis because it will aggravate the uveitis. It is actually a drug that is contraindicated. You will not give pilocarpine. Steroids. See, steroids for anterior uveitis itself, for the inflammation itself, you give steroids. But my question is to decrease the IOP. No. Timolol looks like. Anyway, let's look at option D, latanoprost. See, latanoprost, guys, is a prostaglandin analog, PGF2 alpha analog. It's an inflammatory mediator-like substance, right? So why would you give it in an inflammation like anterior uveitis? It's an inflammatory condition. You should not give latanoprost in inflammatory glaucomas. Okay. So again, no latanoprost. So your answer is timolol. Because the question asks very specifically which of the following is used to decrease the intraocular pressure in anterior uveitis. So it is timolol. Is that clear? Yes. Now next question, evisceration is contraindicated. Did I miss out some question? Okay, pathognomonic sign of pars planitis. Pathognomonic sign of pars planitis, on and only one answer, snow banking. So snow banking means it is pars planitis or intermediate uveitis. Is that clear? Pathognomonic sign of pars planitis is Snow banking. Is that clear to everyone? Put it in your brain box. It's very, very important. Yes. So snow banking, if you see, typically you will see in the inferior pars plana region. Yes, intermediate uveitis or pars planitis. What is the difference between intermediate uveitis and pars planitis? Idiopathic intermediate uveitis is called pars planitis. When you've ruled out every other cause of intermediate uveitis, it's a diagnosis of exclusion. That is pars planitis. Is that clear? Okay. Now, the next question is evisceration is contraindicated in. What is evisceration? When you remove the intraocular contents. See, the eyeball is there. You're just scooping out the intraocular contents. You're removing all the intraocular contents. So the question is, it is contraindicated in when you don't do it. Okay. So you know what this is. Evisceration is. So evisceration is a treatment of choice for panophthalmitis. When you are talking about panophthalmitis, it is a treatment of choice. Whereas it is contraindicated in any case of intraocular tumors. Any case of intraocular tumor. So if any, basically it's intraocular malignancy. Okay. So when you have any malignant tumor inside the eye, you will not scoop it out. You will remove the entire eyeball. You will probably do enucleation if you want. You'll never do evisceration because there might be a chance that you might leave behind malignant cells. So evisceration is contraindicated in intraocular malignancy. Do we have any intraocular malignancy among the options? Anterior staphyloma? No. Anterior staphyloma, you can do an evisceration. Choroidal melanoma. Yes, choroidal melanoma, the most common intraocular malignancy in adults. Yes or no? That is an intraocular malignancy. You will never do evisceration for choroidal melanoma. Sympathetic ophthalmia, yes, you can do evisceration. See, generally we advise enucleation, but nowadays even for sympathetic ophthalmia, we don't even advise enucleation. We do a primary closure and repair. Okay, primary closure and repair, making sure all the exposed uveal tissue is removed. If you want to do something of this drastic kind of surgeries, you can do enucleation of the injured eye. Yes, you can do, but provided the patient has no vision in that eye at all and no possibility of the vision coming back, right? Enucleation. Sometimes patient is psychologically not okay with taking out the eyeball. So that time you can do evisceration, but making sure there is no remnant uveal tissue at all. You're completely removing all the choroid, ciliary body and iris tissue. Completely you will have to remove it. So you can do evisceration. Yes. Anterior staphyloma is when your cornea is ectatic. Okay, your cornea is ectatic following a perforating corneal ulcer or a sloughing corneal ulcer, and it is lined by iris. So it's like bulging cornea which is lined by iris. So it's very very disfiguring. So some people would want to, for cosmetic reasons, you want to have a normal looking eye. So in that case, you can still do an evisceration. Yes, you can do an evisceration. So cut out the bulging cornea, remove all the intraocular contents, provided there is no vision. Okay, there is no vision at all. Posterior segment also is bad. And then you can put in a prosthetic eye following it. Is that clear? Yes? What is? Decimetocele. Decimetocele is a small, only the decimate membrane is popping out. It's like a small area. Wherever there is corneal thinning, that area alone, that is decimetocele. This is the entire cornea. Almost the entire cornea will be bulging. Anterior staphyloma. Okay. Decimetocele is impending perforation. Wherever there is the corneal thinning, that localized area, usually it is very small. Okay, usually it is very small because you can't have a big decimetocele. If it is a big decimetocele, it would have perforated, no? Okay, I got it. Very good. So the question here was about evisceration is contraindicated in, it is contraindicated in choroidal melanoma. Then sunset glow fundus. See, sunset glow fundus is seen in your favorite syndrome, VKH syndrome. Okay, so sunset glow appearance of the fundus is seen in Vogt-Koyanagi-Harada syndrome. It is seen in the convalescent phase. So there are various phases in VKH syndrome. So this sunset glow appearance of the fundus is seen in the convalescent phase or the healing phase of VKH syndrome. Because when you have the acute phases you will have the serous retinal detachment. There will be multiple small subretinal fluid pockets. Okay, so multiple small serous RDs you will see in the acute phases. This is seen in the convalescent phase because of the choroidal depigmentation. Yes. Because you all know VKH is basically characterized by autoimmunity against melanocytes. So the choroidal melanocytes are all depigmented. So that is why you get this sunset glow appearance of fundus. Okay. So we've discussed all the 10 questions. Any doubts here? So UVEA, these 10 questions, I hope it is clear to all of you. Guys, the Christmas sale is still on. Those of you who have told me, ma'am, it's still going on, you're asking. Yes, it is ongoing. The Christmas sale is still ongoing on the EyeMentor app. So the discount is still there. You get a 20% discount on all courses, all the books also. And today evening, 6 p.m., we've got the retina and vitreous quiz. Tomorrow, 11 a.m., I will see you here with the retina and vitreous quiz question discussion. All right. And yeah, morning there has been, I put up a question for you on Instagram. There's a image-based question. And also there is an interesting reel coming up in the evening on Instagram. Watch out on my handle, EyeMentor Dr.Rajarathna. Yes. Yes, there is perilimbal vitiligo also. That is called Sugiura sign. Perilimbal vitiligo in VKH syndrome, that is called Sugiura sign. Okay. Nice. All right. See you. Bye, guys.